Okay, so good evening, everybody. I think that I see by the counter that we are quite a lot of people attending this webinar. So I am sorry, and I want to apologize, Dr. Muna, which is actually blocking the operating room, and she will join us as soon as she can. And she probably will give some word at that moment. So I want to welcome you all. Thank you to be with us. And I want to thank first the EMA OBGYN to organize this session. I think that in that period where traveling is a bit limited, it's very nice to organize those webinars in a short period of time, evening, so we can share our knowledge. And I want also, obviously, to thank AstraZeneca to give us the opportunity to have this webinar. So the title of this webinar is the role of the GnRH in endometriosis and fibroid. And so we are having invited a lot of people. Before, some technical data. So this webinar is live streamed on YouTube, and this webinar will also be available on demand on the MCI Middle East channel on YouTube. And you can participate, and we would like you to be quite interactive and ask questions. And I will try to be the moderator of this question and answer. So type your question in the question and answer box and mention the speaker name you want to address your question. If you have any problem, you may have asked support on the live chat support available on WhatsApp, and you have the number that I advise you to note now, 0569944287. And then at the end of the day, you will get CME credit, and the CME credit will be available, I think, after a few days. So to do this beautiful webinar, we have invited speakers, not only good speakers, but experts and people who knows that, and as they know, they will share their expertise with us. And I saw a part of Dr. Muna and myself. We have Dr. Rajesh Devasi, we have Dr. Wael Samu, we have Dr. Hanan Garbi, and we have Dr. Saad Haswat. So I will present them a little bit more at their turn. And so we can start, I think, with the first speaker. And the first speaker is Dr. Rajesh. Dr. Rajesh Devasi is the head of the Department of Gynecology and Minimal Access Surgery at Dubai London Medical Group. He's very active in the region. He's also very active worldwide. And I always meet him in all congresses I go. So I know that he's perfectly the person to talk. And we will start by the recommendation for treatment of endometriosis. And you know how endometriosis could be difficult. And Dr. Devasi will talk to us about the recommendation of the European Society of Gynae Endoscopy that I got the privilege to be the president a few years ago. So Dr. Rajesh, it's my pleasure to have you, and I give you the floor. So please, let's run your lecture.
Hello and welcome to the 4th Emirates Obs and Gynae Society meeting with the e-version. We have all been in a very difficult situation, and we have been getting used to not so normal routines. And currently, we are in the new norm of life. However, treating our patients and taking care of them does not change, and the challenges that we face remain the same all the time. So therefore, we have a condition such complex as endometriosis, which is always a difficult scenario in the operating room and also in the outpatient clinics to deal and treat with these patients. So we are going to discuss some key points of the many-paged article of the European Society of Gynecological Endoscopy's recommendation on the therapy of endometriosis with the part 1 treatment of the endometrioma. This recommendations was published with the association with the European Society of Human Reproduction and Embryology and the World Endometriosis Society with the ESG. So when you think about endometriosis, endometrioma is the most common problem that we find in diagnosing the lady with. You would find that endometrioma is present in most of the women, up to 70 to 44% of the affected women having an endometrioma. Of course, this itself is not the disease. However, it is a marker of the deep disease. It sometimes appears alone or in combination with the other forms of endometriosis. The invagination and the subsequent collection of the debris from endometriotic implants is the main cause of the pathogenesis theories. However, the colonization of the functional ovarian cyst by endometriotic cells also plays a role. Coelomic metaplasia of the invaginated epithelial inclusions is one of the other most sought after theories. The pathogenesis theories plays an important role in this progressive disease of endometriosis because it is this theory that will be a basis upon how we treat the lady that presents to us with endometriosis. The ESHRE guideline management on the women with endometriosis, the guideline development group formed recommends the clinician should counsel the women who present with the symptoms due to endometriosis thoroughly because the treatment management could be variable in different women. It could be stage-wise. You would start them with the medications, however, you may end up in surgeries because to empirically treat them, you need adequate analgesia, and sometimes some kind of a hormonal treatment like oral contraceptive pills, progestins, or sometimes even more specific targeted therapy like GnRH agonists. It is a common practice that when we do not find any results in such treatment, then we resort to laparoscopy as a gold standard to diagnose endometriosis. However, the response to the hormonal treatment or the non-response to hormonal treatment does not always predict the presence or absence of endometriosis. So, what do we do? Whether we treat this lady with endometriosis, with pain, with empirical therapy, or GnRH agonistic focused targeted therapy. It is clearly a paradox that by recommending empirical treatment in symptomatic young women, one might also induce a delay in the diagnosing of the disease, especially of adenomyosis or deep infiltrating endometriosis, because you would always give an empirical or a GnRH therapy for this lady with an endometrioma, and you would see marked shrinkage in the size of the endometrioma, and you would also see that the patient probably has reduction of symptoms temporarily. But however, the marker of the deep disease, which is the origin of endometriosis, still keeps progressing, because endometriosis, as you all know, is a progressive disease. We see endometriosis even in women who have had hysterectomy. So, the GnRH agonists, with or without add-back therapy, are definitely effective in the relief of endometriosis-associated pain. It could also be curative in early stages of endometriosis, where it could arrest the progression of the disease to a certain limit. However, it can be associated with severe side effects, which could be discussed with the women while offering treatment. We should also keep in mind that when you treat a young lady, you should be also aware of the side effects and the progression, the effective suppression that they could cause on their bone marrow, for example. They should be, while treating endometriosis, they should be focused on treating with a molecule that has also a characteristic to focus on the pain, because most of the ladies has a reduction in the size of the endometrioma, but however there is no effect on the pain. So finally, when you think medically and surgically, the goal is almost the same. You have to improve the pain, you need to improve fertility, you need to preserve the normal ovarian tissue, you have to prevent recurrence, and for all this, you need to ultimately eliminate the endometriotic tissue. What are the assessments that we need to do before the surgery? A woman's age must be of prior importance, because this will determine the goal, the end point of your treatment. What are the symptoms the lady is having? If the lady has more progressive, more symptoms that are directing you towards more deep endometriosis of the bowel or of the urinary system, then probably you need to treat them surgically first. Therefore, a proper anamnesis is utmost importance. And what is the aim of the treatment? Whether you need to improve the pain, improve fertility, ruling out malignancy, because there is a certain percentage of endometriosis women has malignancy. Whether the disease is primary or a recurrence, then maybe you have to defer from surgery. You have to do a bimanual examination, touch the patient and feel them for the disease. How advanced the disease are on the other viscera or organs. Ultrasound and MRI are quite effective in such cases. It helps us localize the cyst, give the numbers, the size. We can also assess the pouch of Douglas involvement by the disease. The rectovaginal nodule can be assessed properly with a good contrast ultrasound scan or an MRI scan, depending upon your expertise. A simple examination which assesses the uterine mobility and nodularity in the vagina by just looking at the vagina through a speculum can make a big difference in assessing the severity of the disease. We have to also look at the hormonal tests to test the ovarian reserve, because in a lady who is 40-year-old who has a prolonged endometriosis history, there's a high chance her ovaries are already failing, and in which you have to assess the function of the ovary in order to see for the prognosis whether she would deteriorate or improve after the surgery. The general recommendations for the surgical treatment of endometriosis of the European Society of Gynecological Endoscopy with the ESHRE and the World Endometriosis Society, Part 1 focuses on the treatment of ovarian endometrioma. So in this study, we have demonstrated that the recommendations include that during endometriosis surgery, especially of the ovary, there should be a traumatic handling of the ovarian tissue. We should be aware of the risk of ovarian damage caused by our surgery. We should think about anti-adhesive prophylaxis, because endometriosis is a surgery that causes a lot of adhesions. Number one, because of the disease, there is already adhesions, for which we do a surgery, and as a paradox, there are more adhesions. The different surgical techniques that are employed, the numerous dissections that we have to carry out, all increases adhesions. And if you're not an expert in endometriosis surgery, it's better to refer the patient to an expert center if you feel that the level and the stage of the disease is far advanced, that one could, whether this patient can be operated by this surgeon in this facility. And then we have to think about this for a better outcome with a single sitting surgery. Patients informed consent with the risk of surgery, the risk of postoperative complications, the risk of intraoperative complications, and of the most important, the risk of the reduction in the ovarian reserve and thereby reduction in fertility. In the initial stages of surgery, we would be encountered with inspecting the cyst, the pelvis, and the abdominal organs, because we have to locate for additional secondary deposits of endometriosis, which may not be seen once you start the surgery. You would spill all the endometriotic liquid from the cyst. You have to have a peritoneal washing prior to the endometrioma mobilization, because once the cyst is out and then you do a washing, the washing is already contaminated by endometriotic cells. We have to perform meticulous adhesiolysis, as you see in the video on the top right-hand corner, to separate the cyst from the pelvic wall completely, to observe the ureter, and to make sure the cyst is freely hanging before an attempt is made to open the cyst and drain it. Sometimes the cyst, as you can see in this video, can open during the process of dissection. This is okay. But however, all attempts should be made to have the anatomy properly visible first. Opening of the cyst to expose the cyst cavity completely, and using the thinnest part of the cyst wall lining to be used as a point to do the cyst wall extirpation, thereby avoiding multiple incisions on the normal cortex of the ovary, because the part that while you dissect from the pelvic wall would be the part that opens the cyst, and this would be the most thinnest part where it causes adhesions to the pelvic wall or to the rectum or to the ureter. We have, once it's open, you need to exposition the cyst completely in order to look for any nodularities, any suspicious malignant potential that's growing within. So this expositioning will also give us the possibility to separate the cyst with the use of a saline irrigation or mixing a vasopressin fluid into the subcapsula of the cyst. Thereby, this could facilitate the dissection of the extirpation of the cyst from the ovarian stroma, and thereby decreasing the possibility for ovarian damage. The cyst should be drained, and then the cyst wall can be opened at the edge, at the most thinnest part of the edge, which had opened already. Or as I said already, use saline or vasopressin solution to aid the identification, dissection of the cyst wall. And if you do not find any cleavage in the cyst wall to delineate the cyst very well, then probably it is better to do an ablation of the cyst wall rather than causing surgical damage and trauma on the ovarian stroma. If the cyst is too big, we consider it more than 5 centimeters, then it's always better to open the cyst with a midline incision. Thereby, you have 2 equal halves to divide of the cyst. Thereby, you have better orientation and ergonomics in handling the cyst wall during the dissection. As I said, adhesiolysis should be done to separate the cyst from the pelvic wall and to observe the ureter, because once you start your cystectomy or the drainage, the anatomy gets even messier, the vision is incomplete, and therefore it causes more difficulty to do the adhesiolysis. Therefore, every attempt should be made to do the adhesiolysis prior to opening of the cyst. And once the cyst is open, the exposition of the cyst cavity completely is the best thing. Use a bag to do the cystectomy. If you have sometimes mixed pathological content in the cyst, sometimes you have a combination of a dermoid and an endometrioma, or a mucinous cyst and an endometrioma, then you could use a endobag to wrap around the ovary and do the cystectomy within the bag. Thereby, you prevent the spillage of the additional pathological contents in this. Irrigation and inspection of the cavity should be done, because if this is obvious to have some kind of contents, then the biopsies can be taken. How do you remove the cyst wall? It should be retrieved either intact through a port or within a bag. So again, if you have an endometrioma intact, the best way to prevent injury to the stroma is to inject some saline, where you are sure to get a differentiating plane in between the cyst and the normal ovarian stromal tissue to get a space to dissect the cyst meticulously, and thereby to prevent damage to the ovary. Because the dissection is quite difficult in long-standing endometriosis or in recurrent endometrioma patients, and it could be more difficult if such step is not employed, and a dissection could become incomplete or causing more harm to the ovary. But however, with a dissection facilitated by an aquatic or medium separation, it could be more easier and could differentiate the different planes very well. So what about ablation of the inner surface of the cyst wall? The first option you have is a laser ablation. I do not perform laser ablation. So, however, the general recommendation of the SGA states that 30 to 55 watts of carbon dioxide laser beam could confirm ablation and on a defocus or a Surgiscan mode, vaporize until the hemosiderin pigment stained tissue changes to yellow-white, use intermittent irrigation for cooling of the tissue, and do not vaporize the entire depth of the capsule. So, if you were to change the color from yellowish white, then this could be pushing the carbon dioxide laser to more deeper depths into the ovarian stroma. However, we regularly use the plasma beam energy ablation, where which the ablation of the inner cyst surface is done with an intensity of a 10 to 40 watt setting. We commonly use a 20 to 25 watt setting. Confirm that this is on the coagulation mode and not on the incisional mode or the cutting mode, and use a perpendicular angle to the cyst. Thereby, you do not change the angle and cause damage to the tissue underneath. That means the stroma underneath. And the vaporization should be done till the hemosiderin stained area becomes yellow-white, like as in any method of coagulation, as you can see also in the video. So you have the ability to focus on certain aspects of the cyst, probably somewhere near the hilum, where there is more proximity to the ovarian vasculature, and focus on the endometriotic implants that are remaining. And this could prevent recurrence. And what if you want to use a normal bipolar electrocoagulation? An intensity of 25 to 40 watt setting should be the norm. Use very short coagulation time. If there is a bleeder, use intermittent irrigation so that you can punctually coagulate this. Be careful about the energy, because bipolar can be very harmful to the ovary if it's prolonged and if it's of a very high wattage. We normally use a standard setting of 20 to 25, thereby having a very lowest range of energy delivered to the ovary. And after the intermittent coagulation, a fluid of Ringer's lactate or saline is installed, thereby to cool the remaining of the ovary. And what about the current literature on ablation? Some proponents say that there are two main techniques to remove the endometrioma surgically. One is to do ovarian cystectomy, which excises the cyst wall, and another one is the ablation, which consists of equally effective method by destruction of the internal surface of the cyst. You can use monopolar or bipolar coagulation. However, monopolar is strongly contraindicated by this study by one of our friends, and ablation using laser or plasma energy has said that it resulted in comparable rates of postoperative pregnancy to those obtained by ovarian cystectomy. The recommendations also say about a combined technique using both excisional and ablative strategies. This can be applied for large endometriomas, prevention of excessive bleeding and damage to the ovarian hilus, because this is where the blood supply is coming into the ovary. So after the cyst opening and drainage is done, a cleavage plane is identified. You have to extirpate 80 to 90% of the cyst wall, and especially if you have the cyst involving the hilum of the ovary, it is better to avoid this part and do a cystectomy up to the ovarium hilus and leave the part in the ovarium hilus, that is, could be the 10 to 20% of the remaining cyst, and use ablation method of a laser, plasma, or bipolar. Ovarian suturing, when does it come in play? When you have some abrupt bleeding that cannot be controlled with your ablative techniques done moderately or done mildly. Do not coagulate and kill the ovary too much. Then you can use a stitch with a very fast absorbable monofilament, which causes less adhesion with the inverted technique stitching, and this could prevent hemorrhage and also could be an added bonus to prevent adhesions. So you could also have the 2 plus a 3-step approach by opening and draining the cyst. Cyst biopsies are taken, and to rule out malignancies, then you stop the surgery, give GnRH agonist therapy like goserelin for 3 months, and then do a second look laparoscopy, cystectomy, or a cyst wall lining ablation. This could be applicable more so ovarian cases with endometrioma of more than 5 centimeters to cause fewer recurrence rate and to have a better ovarian preservation. What about the further options of surgery? Laparotomy is rarely required. In case, if you see that the proficiency is too little for the complexity of the disease, then it's better to stop laparoscopy after the cyst drainage and a biopsy if possible, and give the GnRH agonist therapy for 3 to 6 months. Have a second look laparoscopy, but at the expert center preferably. You could do oophorectomy if the patient is older and if she's not wishing for a child, or she has a very large recurrent or a unilateral endometrioma, where in an MRI evaluation you find that there is a very little residual ovarian stroma left behind. To prevent the recurrence of the disease, this could be the better option for this lady. In multiple recurrent diseases, unilateral ovarian endometriomas, it's better to have a oophorectomy, irrespective of their fertility concern. So we go back to the SHA guidelines management of women with endometriosis. The guideline development group says about oral contraceptive pills, progestins and antiprogestins, that the clinicians should take different side effect profiles of the progestrogens and antiprogestrogens into account when prescribing these, especially because of the irreversible side effects like thrombosis and androgenic side effects associated with this use. The GnRH analogs have found effective, targeted, focal therapy of endometriosis, although we consider this as a first choice of treatment in patients with endometriosis, and if found indicated for women who do not require surgery as a first line of treatment. But the side effects should also be kept in mind, especially when you give GnRH agonists on a long-term use in young girls who could suppress their bone density. Aromatase inhibitors could be done as a palliative measure. However, we do not recommend these unless in a trial setting. I would like to share this paper also, which is a very important message that the European Society of Gynecological Endoscopy, together with the ESHRE and the World Endometriosis Society, give towards the recommendations on the guidelines of endometriosis management in the part 1 and the part 2, that adhesion prophylaxis should be a key strategy in every endometriosis surgery. Our researches are directed towards preventing ovarian failure and improving fertility outcome with such treatment, and endometrioma stripping followed by the application of a polysaccharide agent could avoid ovarian failure because it prevents some hemorrhage that could occur from the endometriosis surgery, thereby reducing the heat that you have to apply to prevent this bleeding, or sutures to prevent the bleeding, could be avoided by using of appropriate adhesion barriers, which also has hemostatic property, and prevent adhesions because we have heat on the ovary, and adhesions are the two key factors that influence adversely fertility in endometriosis surgery. So if you have something that could prevent adhesions and hemorrhage on an endometrioma surgery ovary, this could be a very important factor in improving the outcome of your endometriosis surgery. We also encourage you all, part of the surgical group, to work with us to investigate this possibility and the long-term effect of this combined technique. However, as we know, the recommendations for research keep continuing with different aspects of the surgical treatment of endometrioma. More evidence-based approach is needed to know the necessity and the proper treatment of endometriosis. So the key messages that I would like to deliver today for you to take home would be to exclude all possibilities of endometriosis and assess the patients carefully for deep endometriosis, which would be better treated with laparoscopic surgery. And however, if the patient has no symptoms, to consider the medical management with appropriate focused targeted GnRH therapy in the treatment of endometriosis. Thank you very much.
Thank you, Rajesh, for this lecture. So I'm sorry that probably I misread your title. So it was the recommendation on the treatment of endometrioma. And that is good because our next speaker will go more globally on the medical and surgical approach of endometriosis. So I'm very happy and honored to introduce Dr. Wael Samour, which is the head of the OBGYN department and consultant at the Emirates Hospital in Dubai. And in addition, he's a very good friend. So Wael, welcome. Thank you to share your expertise, and the floor is yours now.
Okay, thank you, Professor. Just I'll prepare.
Take your time, Wael, no problem.
Sorry, there is
no problem. We all have the same problem always. So because you have to put your first slide before you share your screen. That's why.
Yeah.
Voila. You see, perfect.
Sorry. I want to share.
What you can do, you can stop to share.
Yeah, I'll repeat it again. Share screen, advanced.
But take the first, the main keyboard. Voilà.
Yeah. My God. Now you see portion or the full screen?
We see. I'm not sure it's full screen, but you see something. This is the title.
My God.
Yeah, the size, you are oversized. I don't know why.
Yeah, me also.
If you want, I can give the floor to Dr.
Yes, yes, you can give floor for Dr. Hanan, and then I'll correct my slides.
Okay, Dr. Hanan, are you with us?
Yes, I am with you.
Okay, so Hanan, I know that you are very flexible, and I will give you the floor to help Dr. Samour to settle this problem.
Yes.
So Dr. Hanan Garbi is a senior specialist in Latifa. I got the privilege to have her with me for 2 years as a fellow, and I know her quality, so that's why I asked her to give us the updates in adenomyosis. And you know that this is probably one of the part of the endometriosis disease that is a real problem, affect the result of our surgery in both terms of symptoms and fertility. So Hanan, thank you to get the floor like this by surprise.
No, good evening, everybody. Thank you for the organizing committee. I'm really honored to be part of this scientific meeting. Special gratitude for you, Professor, for all this support, and you never gave up these scientific teaching and gathering despite all the circumstances that we are crossing right now. I will be talking about adenomyosis, this enigmatic disease in all aspects, epidemiologic, definition, etiopathogenic, diagnosis, and treatment. So hope that you are seeing my screen and you are seeing me.
Yes.
Okay, perfect. Okay. Of course, I have nothing to disclose. And the entity was first described in 1860 by the pathologist von Rokitansky. And that was the paper published in Vienna in 1806. And he described the adenomyosis as the neoplasia of endometrial glands in the uterine muscle. And many definitions were proposed. However, it was best defined by Bird in 1972, and who described the adenomyosis as the benign invasion of the endometrium within the myometrium, producing a diffusely enlarged uterus exhibiting a non-neoplastic endometrial gland with stroma surrounded by hyperplastic and hyperplastic myometrium. So the gold standard for the positive diagnosis of adenomyosis has been long time the histopathology. And we know that for a long time, this diagnosis was made on specimen of hysterectomy. So the data we have till now are basically retrieved retrospectively. And all the patient included only the patient who needed or who went for hysterectomy. So basically we lack a realistic epidemiologic background. And on the top, there is no standard agreement about the definition of this pathology between the different laboratories. Patients with adenomyosis, they usually present with abnormal uterine bleeding, dysmenorrhea, dyspareunia, and third of the case, they go undetected. However, recently, and I can say over the last 2 decades, we started to see patients with adenomyosis in infertility clinic and seeking for pregnancy, moreover, with pregnancy and obstetrical complication. So the disease is not anymore the disease of Paris lady, multiparous who completed her family. It's now a disease of new population, young fertile patients seeking for pregnancy. So we can say that the epidemiologic scenario has completely changed, and this is a challenge for us as a gynecologist. And this was proved by George Kanz in 2007 when he looked at the MRI of 227 patients with endometriosis and without endometriosis, and he found out that adenomyotic changes defined by a thickening of the junctional zone has commenced earlier or sooner in the life, let's say third decade, and progressed steadily, particularly in women with endometriosis. So the positive diagnosis of adenomyosis, now luckily we have an arsenal of multiple diagnostic tools, and the first line of this is the ultrasound, being widely available, less expensive, and easy to access. It can provide us the positive diagnosis of adenomyosis with high sensitivity and specificity rate. However, we have to confess that ultrasound is highly operator dependent, and we cannot really reproduce the images. Plus, its contribution is very limited if we have coexistent pathology with the adenomyosis. Here, some ultrasonographic feature of the ultrasound. I'm sure all we know now adenomyosis on ultrasound, like bulky globular uterus with hazy endometrium-myometrium interface, subendometrial echogenic striation, which is very specific, the famous question mark where we can see clearly the discrepancy between the uterine walls, intramyometrial cyst, and on the Doppler we can see a hypervascularity crossing a hypertrophic myometrium. Despite it is very expensive, it's not easy to access, time consuming, patient needs to take appointment to access the MRI, but we have to admit that MRI has a significant contribution in young patients, and more specifically when surgery has to be done. Or when we have a coexistent pathology to adenomyosis, I think MRI is the best in mapping the lesion and getting closer to the details so we can tailor the treatment for the patient. There are some standard criteria for the positive diagnosis of adenomyosis on MRI. As we can see here, hypersignal spot on T2, focal adenomyoma, thickening of the junctional zone, ratio junctional zone maximum myometrium thickness more than 40%. And what we have learned, what I personally learned from Professor, MRI is really helpful in the mapping of the lesion, as I said, especially when we have another thing concomitant with adenomyosis. And really it's easy also to counsel, to explain the patient the roadmap of the treatment, the extent of the disease, and to plan the treatment. As you can see here, we just take the picture. Even the picture is more realistic and easy for the patient to understand it more than the ultrasound. As I said, especially for young, fertile, looking for fertility preservation patient. As you can see here, we map the lesion, we design, we explain the patient with the percentage, if there is endometriosis associated, if there is bowel lesion associated. So it is very easy to convey the message to the patient and let her be part of the management plan. Can hysteroscopy help in the diagnosis of adenomyosis? Yes, it does. And now we can see the expression of subendometrium and intramyometrium lesion expressed inside the endometrial cavity. We can see here hyperemic mucosa, what we call the strawberry pattern, the crypt or defect, a bulge of focal adenomyoma or subendometrial cyst. The team from Leuven Institute of Fertility and Embryology has invented what we call uterospirotom, and it is directed to harvest tissue from a local subendometrial or myometrial area where we doubt that there is adenomyosis, and imagine if positive, how clear will be the diagnosis and the management plan. So the principle, it is a cutting helix that fits into a trophy hysteroscope, or it can be visible under ultrasound guidance, and it can collect tissue sent for histopathology. Sensitivity of random needle biopsy is too low for clinical practice. We all agree that the classification and the categorization of the patient is really mandatory. First, to tailor the proper treatment, or to individualize the treatment for each patient. And second, to evaluate the outcome of this treatment. And the first attempt of classification was made by Stefan Gort based on just MRI criteria. He just relied on MRI criteria for this classification. However, we needed a more holistic approach, including the symptomatology, including the morphology, including the histopathology criteria to better guide the treatment. Then Professor Grimbezis from Greece, he had come up with this surgical histological classification, and he had defined 4 major categories: diffuse, focal, polypoid, special categories. Mainly we talk about diffuse and focal, and in the diffuse we have 2 phenotypes or subgroups, where we have it is the extensive form of the disease that invade the whole myometrium. We have the sclerotic form, and we have the glandular form. In the focal, we have the adenomyoma, where the characteristic resembles more to a fibroid with more or less limits. And we have another rare form, which is the juvenile cystic adenomyosis, which is a very rare form that affects young lady and adolescent, and characterized by an ICID endometrium surrounded by a myometrium. And the pathological characteristic looks like endometriotic cyst. And we have rare form like polypoid, typical or atypical. Basically on endometrial biopsy, we found these subgroup. The special category, Jacques Donnet, he sees that what we call rectovaginal deep infiltrating endometriosis is adenomyosis rather than endometriosis. And then recently, all the pioneer of adenomyosis, Stefan Gort, Professor Grimbezis, Professor Rudi Campo, they all collaborate, and they define what we call the hysteroscopic classification, including more criteria and getting closer and closer to what we really need to approach this disease. Coming now to the different therapeutic option for the patient. And we have to admit that young patients who really need fertility preservation treatment, they may require a long-term strategy and integrated approach in order to serve them properly, and including medical and or surgery and or assisted reproductive technique. So we have to admit that previously we used it to take the decision easy. If patient had completed her family, okay, the treatment, if she didn't respond to medical treatment, hysterectomy. However, now we have to think about the category that needs fertility preservation treatment. So the medical treatment, basically it is divided into 2 groups, the hormonal and non-hormonal. The hormonal is directed to oppose the deleterious effect of oestrogenic by inhibiting the ovulation, cessation of menses, and decidualization of the ectopic endometrial gland. The non-hormonal is aimed to reduce the level of prostaglandin and to decrease, to stabilize the immunological environment. For the medical treatment, unfortunately, up to date, we don't have a specific guideline for the treatment of adenomyosis. And basically, we follow the same principle for the treatment of endometriosis to treat patients with adenomyosis. And the treatment may include GnRH analog, progestin, oral contraceptive pill, There are some other drugs under development, and we have to wait for ongoing series to conclude definitively. I will start with this, the GnRH agonist, because with the strong hypoestrogenic effect they do, they are very effective in reducing the pain, the bleeding, and the uterine volume. However, there is no clear consensus regarding the duration, and usually the duration is restricted to 3 to 6 months. This is because of the climacteric side effect. And here, I really invite everyone to prescribe GnRH analog with add-back therapy. This will allow to prolong the duration of the treatment, and it will alleviate the tolerance, it will increase the tolerance of the patient to this treatment, because usually they discontinue mainly because of the side effect. Progestins, we have in the market many molecules available. However, the famous Dynogest, either single, either in monotherapy or associated with estrogen in a pill. However, unfortunately, we don't have the pill available here, but really it can reduce the rate of discontinuation. And the treatment with the progestin needs longer duration to have effect. The effect is gradual, but it is there, needs at least 1 year of treatment. And we have as many as 30% who discontinue the treatment because of side effects. Levonorgestrel releasing intrauterine device, it is very effective in alleviating the pain and the menorrhagia, reducing the level of the prostaglandin. One point only, it is said that the efficacy is reduced within 2 years of use, so it is wise to change the device after 2 years if the patient is having extensive adenomyosis. This medication is under study right now, which is the aromatase inhibitor at the dose of 2.5 milligram per day. It showed that it is as effective as GnRH analog. And interestingly, Kaimura and co-worker, they showed in a prospective randomized controlled trial that the combination of letrozole plus GnRH allowed a significant reduction of the uterine volume by 60% within just 8 weeks of treatment. Coming now to the non-surgical treatment, uterine artery embolization, unfortunately, we cannot recommend it for adenomyosis because the level of efficacy did not reach the same level as we saw in fibroids. Same for high intensity ultrasound energy and MRI guided HIFU. Except trial, experimental trial, these are not recommended for the treatment of adenomyosis because we still lack data and we don't have yet conclusive results. So as said, up to date, the hysterectomy remained the definitive treatment for adenomyosis, and this is a justified option if the patient had completed her family or in case of failure of the other option. But as we said, that the epidemiologic scenario is changing and the condition is identified in childbearing aged women in 25% different phenotype. Infertility now is becoming a clinical presentation of adenomyosis. We all know that the medication, despite being effective on the symptom, they have the side effect of being contraceptive. And the long-term effect of medication is very disappointing. Almost all of them, we have a relapse upon discontinuation of the treatment. So we have to get another alternative to the hysterectomy, and conservative surgical approach had to evolve. And from here came the uterine sparing or the fertility sparing surgical treatment for adenomyosis. And this treatment really falls exactly on the most ethical principle we have been all taught as a doctor. First, do not harm, because at the end, we need to treat the patient and at the same time preserve the uterus. And I really have to say that this type of treatment is very challenging to learn, to do, and to teach. And it requires a lot of wisdom, a lot of expertise to go for it. And the general principle for any conservative surgical treatment is to preserve, is to treat or excise the diseased tissue while preserving the integrity and the subsequent functionality of the organ. However, we all know that adenomyosis infiltrate the myometrium without a clear border. And while excising, we are forcibly removing part of the healthy tissue. So the challenge here is to balance the advantage of being radical towards this disease against the disadvantage of leaving a defective or destructive uterine wall that may lead to a functional hysterectomy. Coming now, moreover, the adenomyosis, we all know how close the etiology and how linked are adenomyosis and endometriosis. We see these two pathologies together in almost 80% of infertile patients, who are basically the target population for this fertility sparing surgery. So the surgeon has to be really ready to deal with the two conditions at the same time without impairing the fertility. So in such case, you have to clearly here she has a nodule in the bowel, she has bilateral endometrioma, she has hydrosalpinx, and she has extensive posterior wall adenomyosis in communication with a rectovaginal nodule. So to reach the step of adenomyoma, we have to do a lot of work. Coming now to the surgical treatment per se, and Professor Grimbezis has classified this treatment on excisional and non-excisional. In the excisional, we have the complete, and we have what we call the cytoreductive surgery or partial excision. I'll try to go fast through the different technique. The classical technique, the steps follow, it is mainly aimed for a complete excision, and the steps follow almost the same as myomectomy, from vasopressin injection, serosal incision, enucleation, and then suturing of the residual cavity. However, you have to keep in mind that they have a very rich vascularity, traction and pulling is very tough, and the excision is made in neighboring a healthy tissue. Approximation of tissue also is very hard because the edges are fibrosed. The triple flap technique, it was described as a laparotomy technique by Osada and aims for a complete excision. As I said, they are highly vascularized, so all precaution to reduce the blood loss intra-op has to be taken, ligation of major vessel, vasopressin, tourniquet. So basically the surgery started by bisection of the uterus in the sagittal axis until opening the cavity, and the opening is made intentionally in order not to open the cavity elsewhere, and in order to spot the point and go all around, and to spot also the cornea in order not to damage them. And you can see here he made an incision 1 centimeter from the endometrium and 1 centimeter from the serosal edge, and all the tissue is excised in between. Same on the other side. And then closure of the endometrial cavity. Then here irrigation to reduce the risk of infection. Then one side seromuscular is closed. Then he's sculpting here to refresh the edge, and one side anteroposterior, and then the other flap will come in a such way to cover it. Overlapping technique or palto, it is the same principle. Also we bisect, however the reconstruction is a bit different. Same, opening the cavity and then excise the adenomyotic tissue, and then the overlap. One side from the seromuscular layer will be the down one, and the other one will come over it in order to fill up the dead space. You can see how he's sculpting the edge and refreshing for a better healing. You see, like palto, in fact. And then you see one is down, one is over it. So it's like a strengthening or reconstruction of the walls. This is one of our patients. It is a wedge resection that we closed in overlap technique, and you can see clearly here how extensive is the disease. You can see the dilated ectopic gland filled up with chocolate material. You can see here it is very wise to use the cold knife to avoid as much as he can the use of energy, and to keep viable, healthy tissue vascularized. You can see here, he opened the cavity. As I said, it is better sometimes to open the cavity in order to avoid it opening in many places. We don't pass suture inside the endometrial cavity, we just bury it. We see how much we remove, but still the tissue left is still diseased. But we have to know the limit. How much is enough? How much is enough to close? How much is enough to leave enough uterine wall? Overlap technique, we took one side down and the other side will come on the top of it. It's a cytoreductive technique. The aim is partial excision. Another patient from our series, she consulted us at the age of 34 years old with the whole picture of adenomyosis, dyspareunia, dysmenorrhea, menorrhagia, and infertility. This patient was sent for us basically for fibroid, as I can tell you that till today that there are some people who confuse fibroid and adenomyoma. But you can see clearly the discrepancy between the walls. There is no junctional zone, almost you can see around the endometrial cavity. We start always our assessment with hysteroscopy, especially for patients seeking for fertility. And as I said, endometrial cavity has the print of subendometrial lesion. You can see here the crypts, the blue spots, the hyperemic, hypervascularity, the stretching of the muscle. You can see also in the panoramic view how the cavity is tilted by the weight of the posterior adenomyoma. Again, we start all precaution to avoid unexpected blood loss is taken. Here we ligate the uterine artery at their origin, vasopressin. Again, it is very wise to use the cold knife. It is different than the other one. You can see it's like purely sclerotic. We don't see that much gland like the other case. It's endless. That's why I said it's requiring a lot of expertise. Somebody used to do this type of surgery. It's not easy to do. You have to keep symmetric edge. You have to keep your suture not under tension. Again, we don't pass suture inside the endometrial cavity. We just bury it with monocrete to 0. And then he just like professor, he did like a mapping of the suture line to bring it symmetric. This is Surgisert to avoid hematoma formation post-op. Always we remove the clips before morcellation, so to see eventual bleeding. We reassess again our cavity. You can see there is no suture material inside. She has a very nice cavity, and still we put anti-adhesive gel. This is our protocol usually that post-op, any adenomyomectomy, post-op we keep them 6 months under GnRH plus add-back therapy. Why? First, it will be like an adjuvant therapy. Second, it will be like a guaranteed contraception to allow proper healing before going for any pregnancy. This is her MRI 6 months after the surgery and the treatment, and you can see the difference clearly, how symmetric are the posterior and the anterior wall, how nicely is drawing the junctional zone and the cavity. I just want to remind you, this was her MRI pre-op, as if they are 2 different patients. The rare form I just talked, which is the cystic juvenile adenomyosis, usually, as I said, it is rare, young patient, and the picture on the ultrasound looks like interstitial ectopic pregnancy, and on the laparoscopic view looks like a broad ligament fibroid. But you will see here a blue spot on the top, vasopressin, and here the challenge is to excise in sano without compromising the interstitial portion of the fallopian tube, trying to remove it intact. As I said, this type, they resemble more to an endometriotic cyst, and the content is chocolate material. This video is from Dr. George Postifidos from Greece. And then we close the residual cavity monocryle, and you can see the content of the lesion. Hysteroscopy, as it helps in the diagnosis and the positive diagnosis of adenomyosis, it helps also in the treatment of adenomyosis. And now we are able to do type 1 myoma even in office setup using mini resectoscope without any dilatation. We can also do adenomyomectomy in some selected cases with pre-treatment GnRH, and if it is less than 5 centimeters. And the diagnostic hysteroscopy, and always I recommend to reduce the pressure, so you allow the bulge of the lesion inside the cavity. You'll see it now clearly and nicely. You see the bulge of the lesion. Reduce the pressure to 40 instead of 190, like this, 90, 100 millimeter of mercury. And then here is the treatment. As I said, there is no dilatation. This is office setup, and you can really serve the patient. These are coming from the day cases of Professor Rudy Campo from Belgium. You can see the content here of the lesion. I move endometrial resection, including 2 to 3 millimeter from the endometrial thickness, can be very helpful using the loop to alleviate the symptom associated with adenomyosis. And it has been demonstrated that transcervical resection of endometrium plus Mirena IUCD really gives good result in terms of menorrhagia and dysmenorrhea relief. How effective is the hysteroscopy? This answer is coming from China, where they recruited 42 patients. All of them, they got hysteroscopic excision of myometrial lesion. This study is quite good because they took the care to exclude the patient who has endometriosis that may interfere with their symptom. And they excluded also the patient on GnRH. And they followed up these patients up to 2 years. And you can see here that 100% of these patients, within 3 months, they got rid of their menorrhagia. 95% of these patients, they got their dysmenorrhea relieved. And this percentage remained highly positive even 2 years post-op, 84% and 86%. Another paper in favor of GnRH as an adjuvant treatment to surgery from Taiwan, and here they recruited 165 patients, randomly divided into 2 groups. One group who had medical followed by 6 months GnRH, and one group who had only surgery alone. Interestingly, the group who had surgical plus post-op medical, they have less relapse in post-op, and they have only 28 relapse. Comparing to the group who had surgery only, they had 50% relapse. So surgical plus medical treatment provides more effective symptom control and less relapse rate than surgery alone, up to 2 years follow-up. This is the experience of Professor Christofidis from Greece, where he recruited 92 cases. All these cases, they got fertility sparing laparoscopic treatment. And what he noticed that he had 2 major groups, the diffuse, which is by far the most common form, he had it, and the focal. In the focal, he defined 3 phenotypes. We talk about them, which is the sclerotic, where the characteristic resembles more to a myoma, and the nodular form where the characteristic looks more deep infiltrating endometriosis nodule, and the cystic form we just saw looks more an endometrioma. In the cystic and the nodular form, the treatment was 100% complete, near complete in the sclerotic form. However, in the diffuse form, 85% has to go for hysterectomy later on. So it is quite impossible to treat with fertility sparing treatment the diffuse form. Another systematic review from Greece also, where he looked at 64 studies with 1,094 patients, and he compared the complete excision to the partial excision. The patient who had complete excision, they got better menorrhagia control and higher pregnancy rate. However, the patient, in terms of dysmenorrhea, the two groups, they got the same result. Reproductive outcome after fertility sparing treatment, and this paper coming from Denmark, also it's a systematic review of case series, and they recruited 338 patients, and some of them they conceived spontaneously, other they needed assisted reproductive technique, and they got a total of pregnancy rate of 47% with live birth, 37% after fertility sparing surgical treatment. These treatments sound very attractive, the results are very positive, but I have to say that this treatment is very mutilating, very aggressive, and more, it has a lot of obstetrical repercussion. And if the rate of uterine rupture after cesarean section is less than 0.5%, I can tell you that after adenomyomectomy, this risk goes up to 6%. So we have to be very careful, and data supporting this type of treatment are suboptimal. Moreover, adenomyosis, whether treated. Yes, Professor.
Can we go to the end, please? Because
yes.
we are over time. Thank you.
Yes, I will just share these few cases. This is a case of 36 years old who consulted professor in Strasbourg after a long trip of IVF, and all of them failed, and symptomatic adenomyosis. She has 3-compartment disease, bladder, bowel, adenomyosis. She got the full treatment with the bladder and adenomyomectomy and bowel resection. I just share the part of adenomyoma. Anterior wall, as you can see. I'll just make it fast till here we use the ultrasonic device. And here is the final. I can say 6 months later, we got the good news that this patient got pregnant spontaneously. Unfortunately, by 25 weeks, she ruptured her uterus and she lost her baby. So really, it's a nightmare, and all the data suggests that this rupture in adenomyomectomy occurs sooner than after fibroid. And it has a lot of risk factors, especially that we depend a lot on energy, on minimal invasive surgery, post-op infection and hematoma, and the short interval between surgery and conception, and of course, surgeon skills. So we have to deal with a patient with adenomyosis, whether treated or untreated, as a high-risk pregnancy, more and special attention with patient who had passed adenomyomectomy. So GnRH is a good option to allow a reliable contraception, and data showed that in extensive cytoreduction, resumption of blood flow is noted after 2 years. So I will conclude, we need to get an adequate diagnosis. We have to centralize the patient perspective. Cytoreductive surgery only after repeated IVF failure, and adenomyosis is not a cancer, so radicality is an illusion. I invite you all to join us in Dubai, Dubai 2021, which is a special edition this year because of Corona, and see you all there. Thank you so much.
Thank you, Anan. Alors, obviously, and I knew you are a little bit over time, but
As
it was so interesting that I didn't dare to stop you earlier because I think that you make a real overview of the problem, and it will be let's say, very helpful for people in front of this difficult disease. So we will discuss after that. So it's my pleasure now to invite Wael. I hope he fixed his problem. I'm sure he did it. So Wael, can you give us an overview of the management of the endometriosis, including endometrioma and adenomyosis?
Sure. Good evening again. Sorry for the inconvenience and for the technical problem. Do you hear me, Arnaud?
Yes, I hear you. Perfect.
Okay. And the slides is clear?
The slide is perfect.
Okay. First of all, good evening, dear colleagues and friends. Thank you, Professor Vattiers, and thank you also for EMA and AstraZeneca for inviting me for this meeting and the presentation. Tonight, I'm going to present and discuss with you very difficult topic, the management of endometriosis. As you know, nowadays, there are congresses over a few days discussing only endometriosis. So I'll try my best to highlight different points in this topic. As you know, there are superficial endometriosis, deep infiltrating endometriosis, and ovarian endometrioma. And of course, just the topic discussed now by Dr. Hanan, the adenomyosis. We have different options for management of endometriosis: expectant, medical, surgical, both medical and surgical, and ART. This is in general. Now, I'm going to discuss each topic separately as much as time allowed. Starting with the expectant management, the question, can we wait before treatment in certain conditions? Yes, we can wait and observe in some cases, like for example, minimal, mild, moderate lesions, and if there is no symptoms, and also in case of accidental finding of endometriosis during laparoscopy. For pain management, it's possible to offer medical treatment or surgical treatment or both together for pain management. While for infertility management, we have mainly two options, surgical and ART. And in mild or minimal cases, expectant management could be chosen. Medical management is ineffective for treatment of infertility. This is important. So, surgical management could be helpful in pain and infertility. As a conclusion, I start with the medical treatment. No steroidal anti-inflammatory drugs considered by some authors, non-steroidal anti-inflammatory drugs considered by some authors as first-line treatment for endometriotic pelvic pain, but there is no high-quality data supporting this. It is available, cheap, and acceptable side effects. If the pain is mild or moderate and patient want to conceive, we can offer here non-steroidal anti-inflammatory drugs alone. If the pain is mild, the same, or moderate, and the patient doesn't want to conceive, we can prescribe here both non-steroidal anti-inflammatory drugs and continuous hormonal contraceptive rather than either agent alone, because, as I mentioned, low risk of the drugs, low cost, a few side effects, and well tolerated compared to the other medical therapies. Oral contraceptive pills considered also as a first-line medical treatment of endometriosis. The advantages, as I mentioned before, plus long-term use, it is easy to use, provide contraception, and decrease the risk of ovarian and endometrial cancer. There are data from randomly assigned trials support estrogen-progesterone therapy to reduce pain. But another one meta-analysis trial conclude that the evidence was insufficient to make this conclusion. Both cyclic and continuous hormonal regimen reduce endometriosis-related pain. In one meta-analysis, it is reported that continuous COX regimen were more effective at reducing pain symptoms than cyclic one. Now, progestogens. The most common used progestogens are MIPA for injection, norethindrone acetate with a dose from 5 to 15 milligram daily, and Dynogest tablets twice milligram oral daily. When compared with the placebo, MPA and Dynogest were superior, and the treatment outcome are similar with Dynogest or norethindrone acetate. But norethindrone acetate is less expensive. This means that the result when using MPA or Dynogest are comparing with the placebo, both are good, but the advantage of norethindrone acetate is less expensive. When we compare progestogens with combined oral contraceptive pills, there is no estrogen-related thromboembolism with the progestogen. When we compare the progestogens with analogs, it is not associated with bone loss and it is less expensive. This means this is in favor of progestogens. Danazol have many side effects and rarely used nowadays. There are general side effects of progestogens like irregular uterine bleeding, spotting, weight gain, mood changes like depression, and there are other specific side effects for different progestins. For example, with Dynogest, amenorrhea, with long-term use of MPA, bone loss, with long-term use norethindrone acetate, significant reduction in HDL and significant increase in the LDL and triglycerides. Etonogesterol, like nixplanon or previously implanon, found to be effective in some studies in reducing all types of endometriosis-related pain like, for example, dysmenorrhea, non-menstrual pelvic pain, and found in some studies to have the same effect of reducing pain when compared to the MPA. We come to the levonorgestrel releasing IUD. It was found in the review of 3 trials that LNG IUD reduced post-operative dysmenorrhea. It has side effect which cause abnormal uterine bleeding, mainly amenorrhea. But the good thing with the IUD, Mirena, that it doesn't affect bone mineral density or lipid profile, which is a side effect by other medical treatments. In this slide, I want to show the study reported recently in 2018 that LNG IUD also produce therapeutic effect on the ectopic endometrium, not only inside the uterus, also outside in the pelvis. When it comes to the analog, in case of severe, we can use it in case of severe symptoms or recurrent symptoms or failure of other medical treatments. In this case, the analog together with add-back hormone therapy is recommended. Not alone, together with the add-back therapy. Some experts use the analog as initial treatment from the beginning, before any other medical treatment. A meta-analysis of 41 trials in this study, including nearly 5,000 women, reported that the analogs is as effective as other medical therapies because they compare it with other medical treatment which used before it for relieving pain. And still, the meta-analysis conclude that the evidence was limited regarding the optimal dose, how much we are going to give, and the duration of the treatment, how long, 6 months, 12 months, 10 years, as we will see. Also, it was found that no route of administration appeared superior to the other. It is concluded that the analogs treatment has demonstrated efficacy without the risk of negative impact on ovarian reserve, which is important. A small number of clinical trials and small cohort studies in this here showed that the agonist plus add-back can effective up to 10 years of a treatment. This is one study, but really I doubt it, and it could be discussed later with the other colleagues. This is too much because the FDA, they approve its use with add-back only up to 12 months. And in another report by other experts, I guess to 2 years. In case of severe side effects of analog, we have a solution or two options to lower the dose and keep it effective. And these two options, one of them is titration method and the other is longer interval method. The first one, we reduce the nasal spray dose gradually over 1 or 2 or 3 months. This means titration of the dose by keeping the minimal effective dose to remain the patient amenorrheic. This means effective. And the other scenario, the long interval method, in case of injection, it is possible to prolong the time interval for the injection to be every 6 weeks instead of every 4 weeks. Still, it will be effective in improvement of pelvic pain and dysmenorrhea. Regarding the add-back therapy, there are many options available in the market to use as add-back therapy. For example, norethindrone acetate, different combination of estrogen and progesterone, hormone replacement therapy, tibolone, low or microdose estrogen. If we consider the agonist plus norethindrone acetate 5 milligram, it is by FDA approved and recommended as first-line therapy. So agonist plus norethindrone acetate 5 milligram considered as first-line therapy by the FDA. Regimen of agonist with low-dose estrogen plus low-dose progesterone as add-back for the treatment of pelvic pain caused by endometriosis has not been approved. So estrogen, in this case, it is not approved. Estrogen plus progesterone. If estrogen used alone, it is recommended to use low or micro dose estrogen add back, for example, transdermal estradiol up to 0.025 milligram per day. With this dose, it will not cause, it will treat the endometriosis, it will not affect the endometriosis pain, and it will not cause endometrial hyperplasia. In this study, it is concluded that the addition of hormone replacement therapy to the agonist for treatment of endometriosis do not reduce the efficacy of the treatment, and this is important. And in the same time, the adverse hypoestrogenic effect were decreased, but not completely abolished. To avoid the side effect of the agonist, the question when to start, we have to start the add-back, then when to start the add-back treatment. There are two options to start the add-back treatment with the agonist. One is immediately or 6 months later. There is no advantage to wait to add the add-back therapy a few months later. And this is by Asram in 2014. They recommend to start the analog therapy and add-back in the same time together. Aromatase inhibitor could be used in the treatment of severe refractory endometriosis related pain. And in this study, when aromatase inhibitor added to gozerline therapy, which is the agonist, it was found that there is significant increase in the pain-free interval and decreased symptom recurrence rate. This is good. Antagonist could be used for moderate to severe pain-related endometriosis. It is used when other medical treatment failed as another medical option. Danazol, due to its side effects, mainly the androgenic side effects, rarely used nowadays. Now, when it comes to the surgery, first we have to exclude other causes of pelvic pain. Then the indication for surgery are failed or refusal or contraindication to medical treatment. If the treatment doctor want to confirm the diagnosis by histopathology, or there is suspicious of malignancy in the adnexal mass. Of course, beside if there is any obstruction in the urinary or intestinal tract. Do we need post-operative medical treatment or suppressive therapy? Asram in 2014 and Cochrane review didn't recommend a pre-operative medical suppressive therapy. It is not recommended because no evidence that it decreased the extent of the surgical dissection. Also, it prolongs the duration of the pain relief, and it doesn't increase the future pregnancy rates. It doesn't decrease recurrence rate. So it is not recommended. Now, surgical procedure, there are different surgical modalities and options are available from exploration, diagnosis, pelvic endometriosis, destruction of endometriotic implants, coagulation, excision, ovarian endometrioma drainage, cystectomy or oophorectomy, adnexectomy, name it, up to total surgery and bilateral salvage or oophorectomy. First of all, it is important to start inspection of the pelvis for endometriotic lesion. When you go for laparoscopic surgery, it is important to inspect the pelvis for endometriotic lesion, to evaluate the pelvis, and also to check the appendix, because there is up to 4% of women with endometriosis have appendiceal endometriosis. Now, conservative versus definitive surgery. Conservative surgery is excision or ablation of endometriotic lesion. with preservation of the uterus and the preservation as much as possible of the ovarian tissue. When comparing conservative laparoscopy surgery versus only diagnostic laparoscopy, it is found that it was found in this Cochrane review, which was published in 2014, that conservative laparoscopic surgery reduced the overall pain and increased live birth or ongoing pregnancy. And these results are better in favor of conservative management than not only diagnostic. For endometriotic implants, I am now discussing the endometriotic implants only. There are two options, excision or ablation. There is no single modality whether ablation or excision is superior. Pain relief is approximately 75% of patients who undergo laparoscopic ablation or excision for endometriosis, but the risk of recurrence is up to 40% at 10 years follow-up, and approximately 20% of patients need additional surgery within the next 2 years subsequent to the first one. During laparoscopic surgery for any indication, and in the same time, you don't want to operate on the endometriosis, accidentally you find endometriosis, it is a good idea and maybe important to obtain tissue for histological confirmation of endometriosis for further treatment and follow-up. In a large retrospective study, the study published in 2017 for over 50,000 patients who underwent initial laparoscopic resection or hysterectomy, the reoperation rate at 8 years of follow-up were 35% for resection and 5% in case of hysterectomy. Adhesion, I'd like to remind you, if you operate and you plan to operate for endometriotic patient, you have to expect adhesion as reported in this study up to 70% of women, both with and without prior surgery. So it is important to know the anatomy and to have good experience in adhesiolysis and in endometriotic surgery. FDA approved different products as adhesion barrier after pelvic surgery like Intercede, Cibrafilm, and Adept. Now, hysterectomy. When to go for hysterectomy if failed medical therapy, failed conservative surgery, a patient with persistent symptoms of endometriosis, do not plan future childhood or childbearing, avoid reabortion, and if there is another indication for hysterectomy. This is debatable and could be discussed in details. What about oophorectomy? To do oophorectomy or not? When it is indicated to remove the ovaries. Oophorectomy could be done for patients approaching the menopause, for patients with extensive disease involving the ovaries, for patients avoiding risk of reoperation. But no data established at what age cut-off value for oophorectomy. We do not know which is the optimal age to go for oophorectomy. Generally, oophorectomy is not advisable in women younger than 40 years. What about post-operative management? Do we need treatment or not? Asram and Ishri advising post-operative medical suppressive therapy for most women treated surgically for endometriosis. All medical treatment could be used in individual phases, whether COX, progestins, or analog, or IUDs, etc. So it is recommended to be used after surgery. For how long the post-operative medical treatment could be used for suppression of endometriosis. It ranges in the literature between and definitions by different authors between, and guidelines, of course, between 6 months up to 2 years. Few slides or discussion about endometrioma. This topic also, it is a hot topic, how and when to operate endometrioma, and in each presentation there is a debate with and against and when. As you see here, if we go for observation, there are two options, observation or surgical resection. If we go for observation, the advantages is preserve ovarian function. And this is, in my opinion, the most important thing. And in the risk, the most important thing, in my opinion, also inability to exclude malignancy. While if we go to surgical resection, the advantage or the most advantage in some cases, exclusion of malignancy, and could be the definitive diagnosis, while the risk is decreased ovarian reserve. The trend now to avoid surgery as much as possible. What is the cut-off value of excision of endometrioma? Nobody knows. As you see here, there is no cut-off value. For example, the size of the endometrioma to be removed in 2005 by ISHRI, more than 3 centimeters, by SOX. In 2010, more than 3, the same. ASRAM, 2012, increased it to 4 centimeters and for pain. And then they change and they put only large without definition, exact definition of the size in 2014. ISHRI in 2014, they do not put any cut-off value, and NICE regulation or recommendation in 2017, they didn't mention any cut-off value to remove the endometrioma. We follow up our patients if, the observation option, we can go for observation and follow up our patient. If the endometrioma is small, less than 5 centimeters, asymptomatic, and by imaging, there is a characteristic of an endometrioma to rule out malignancy. The indication for endometrioma excision is for treatment of pain and subfertility if the endometrioma is large and expanding in size, confirmed diagnosis in some cases, exclude malignancy in other cases, prevent complication, and treatment of other associated lesions. But here I'd like to also to mention that the final decision for surgery must be individualized case by case. In this Cochrane review published in 2008, excision of endometrioma improves pregnancy rate, increase spontaneous pregnancy, and reduce rate of endometrioma recurrence. And this is also for further discussion and could be debatable. Ovarian reserve, it is very important point. ISHRI guidelines concluded that, in contrast, and this is important really, ovarian surgery to remove the endometrioma can reduce ovarian reserve as assessed by anti-Mullerian hormone levels, but not by antral follicle count. So, which is more, we'll come maybe for another study here. This review and meta-analysis published in 2014, and this is continuation for the previous conclusion. They conclude here from this systemic review, in the affected ovary, the antral follicle count is lower before and after surgery. This is clear and this is expected. But the antral follicle count didn't appear to change significantly after surgery, which is really a little bit strange. But it is fact. While there is heterogeneity of the published study and the anti-Mullerian hormone as marker for the reduced ovarian reserve. This means it is not clear with the anti-Mullerian hormone, the result, especially after the surgery. So antral follicle count may be more specific marker of ovarian, so anti-follicular count may be a more specific marker of ovulation, anti-follicular count may be more specific marker of ovarian reserve related to the surgery. This is more sensitive than anti-Mullerian. So the antral follicle count is more sensitive in case of surgery more than the anti-Mullerian hormone.
Well,
yes.
2 minutes, please.
Okay.
Thank you.
For the deep endometriosis, after surgical removal, endometrioma recurrence has been reported in approximately 25% of the women. I'll skip a few slides and I'll go to maybe more important. Yeah, in case of infertility and asymptomatic endometriosis, no need for surgical treatment, as the impact of asymptomatic endometriosis in the infertility is not known, and the risk associated with the surgical resection are not warranted. In case of infertility and symptoms of endometriosis, surgery to resect or ablate the endometriosis increase post-operative pregnancy rates compared with no treatment. Now, in case of, these are a few slides could be helpful practically. In case of moderate to severe endometriosis, that is to say, stage 3 or stage 4 endometriosis, or those with endometrioma, they will benefit from ART. If no or there is reversible infertility factor like polyp or fibroid, plus minimal or mild endometriosis, stage 1, stage 2, and the patient younger than 35 years, a treatment to give her chance for natural conception for 6-month trial. If failed, ovulation induction with IUE 3 trials, and if failed, for IVF and ICSI. As before, but if the patient is more than 35 years, first-line treatment, ART directly. If not possible due to any other reason, then financial or any other reason, then of ovulation induction and IUI. If non-reversible infertility factor, of course, to go directly to the ART. As a conclusion, I have 3 slides maybe. When managing endometriotic patient, consider all these factors mentioned by Dr. Rajesh, symptoms, location of the disease, size of the endometrioma, adenomyosis, dye, patient, age of the patient, history of previous treatment, surgical, medical, pelvic, other pelvic lesion, cost, and important counseling the patient. Starting with empirical medical treatment for 3 months is appropriate. However, the presence or absence of response to empiric treatment cannot explain a definitive confirmation or exclusion of the diagnosis. Endometriosis is a chronic disease, require lifelong management plan. The goal of the treatment, maximizing the use of medical treatment and avoiding repeated surgical procedures. And the last recommendation or conclusion, the one before, the optimal management of endometriosis and its related symptoms is still not completely clear. Extent of the disease correlates poorly with the severity of the symptoms. And this is the last two sentences. Treatment decision must be individualized, depending on all factors I mentioned. And one of the most important point is counseling patient in management plan is very important. It is not the decision of the doctor alone. After counseling, the decision will be from both sides, doctor and patient. Thank you.
Thank you, Wael, for this extensive algorithm of decision. Obviously, it become a bit difficult. So I don't know. Normally, we have some question and answer. We are a bit late because we were a bit over time on the lecture. But I think that we can still get. I want to tell you that we are a lot of participants. I see there are more than 560 participants. So it means that we have done the job, or you have done the job. And surprisingly, I have very few questions from the audience. And so I can start by Dr. Rajesh. And I just want to ask you a question, Dr. Rajesh. Tell me something. In your experience, the medical treatment and mainly the treatment by GnRH agonist, does it reduce the size of the endometrioma? Rajesh? Where is Dr. Rajesh? I don't see Dr. Rajesh. Ah, he disappeared. You want to make an answer? Well, in experience, does the medical treatment, let's say overall medical treatment, reduce the size of endometrioma?
Yeah, there is some studies, they said that it reduces the size of endometrioma with their combined oral hormone, oral contraceptive pills. The size of the endometrioma stay as it is. Some studies, they said that it is decreased, and the same is applicable with the analog. There is no strong evidence that there is, even with the Dynogest, they said that some studies, there is a reduction in the size of the endometrioma, but there is no strong evidence to say that medical treatment will reduce the size of endometrioma.
Okay, so you say, your answer is yes.
In some cases, not in all cases.
Alors, always, and Anan, you can participate if you have to comment. I have a question. Well, what is the progestogen, dihydrogesterone in medical treatment of endometriosis, or does it have any place in the post-surgical treatment?
Really, this is a good question. I guess it depends. It is individualized. It depends on the case. If the patient is young and she has severe endometriosis, I prefer to go to analog directly. And then later, after, let us say, 6 or 3, 6 or 12 months, depending on the case and what is the desire of the patient, then I can shift to the oral contraceptive pills or to the progestogens. And the progestogens is one of the first line medication. And it could be used after the surgery if it is mild, moderate directly, but if it is severe, then I prefer to go to analog with add back for a certain period, then followed by the progestogen.
Okay. I hope you still we still have sound because the sound was a little bit dropped. Anan, I have a question for you. Why is there is a change in the? First of all, why? First of all, does it? Do we see a change in the epidemiology of adenomyosis? And if yes, why it is so is that our advancement in diagnostic modalities or patient factor?
Actually, for both, Professor, thank you for the question. Actually, for these two reasons, we have a change in the epidemiology. Are you hearing me?
Yes.
Yes? Okay. Because patients nowadays are getting married and they are trying for the first pregnancy at an older age. This is one. Second, we have a clear advance in the imaging and diagnostic tool.
So both.
Yeah.
So you confirm the fact that we see more adenomyosis that we were saying before.
Yes, 100%.
Okay. I want to say that in the study done on histopathology of specimen after hysterectomy, the presence of adenomyosis has been found up to 87%. So it means that the conclusion that adenomyosis could be also a mode of the uterus to be elder.
Yes.
And so that
senile.
that's why that's why the histopathological diagnosis of endometriosis is very important and very difficult sometimes.
Yeah.
Okay. Alors, Anan, I still have a question for you, for your friend Zainab.
Yes.
So after surgery, when is the best time to start GnRH analogs?
Actually, immediately after surgery. Usually we start day 7 after the first period that comes after the surgery to avoid the flare-up, the estrogen flare-up. But immediately after surgery, we start GnRH analog.
So I have a question for you, Wael, if you are still here.
Yeah.
You said in your lecture that I think this is the ASRM that say you have to start the add-back therapy at the same time of the agonist. In my practice, I like to start 2 weeks after. And what is your experience? I start with the agonist and I give the add-back 2 weeks after.
First of all, before, long time ago, we started the add-back therapy after 6 months. Now, the new studies, they recommend, and as we said, by other guidelines, that to start it immediately. Really no need to wait for 2 weeks. You can start immediately, and I find nobody recommend to, or at least I didn't find in the literature that they recommend to start it after 2 weeks. So I started really immediately, both together.
Okay.
And I started from the first, immediately after the surgery.
And you give estrogen only, or you give estrogen and progesterone in your add-back therapy?
Look, I'll give, in my experience, I tried everything. According to the FDA, they recommend the NITA, norethindrone, 5 milligram. But in my practice, I use Tibilone, Livial. I find it very effective, and the patient, they are happy with it.
Do we have Tibolone in Dubai? UAE?
Yeah, I mean, the problem here, sometimes you don't find all medication in the same time, but you find them sometime, and sometimes they can arrange to get it even by online.
Well, we can do a business. We can do a business. Well.
What about the estrogen patches, Wael?
Yeah, you can. Yeah, it is possible. As I mentioned, it
because
is possible.
It's available here.
It is possible to use the progesterone alone or progestagen, estrogen plus progestin, hormone replacement therapy. You can use also, as I said, Tibilone. And for the patches, really, I use it before as estrogen alone, especially for those patients after hysterectomy. you do not need progesterone.
But there are some studies that progesterone are good for health. Huh? And,
yeah, I mean, yes, yeah, right. But there is different studies. Some they recommend to use a progesterone, and some they do not. And
yeah,
we used in the old literature not to use it.
But I think it would be useful for everyone that we try to stabilize what are the indication of the add-back therapy and which mode, because I think that everyone does a little bit his kitchen, and so it's a bit difficult for everyone to try to adopt a model. Rajesh, I have a question for you. A case of abortion following a spontaneous conception, and after the follow-up of the miscarriage, they discover an endometrioma of 4 centimeters. You want to start to get a pregnancy, what to do? Surgery or allow the pregnancy without trying the surgery?
So this patient has any symptoms? Did she have problem conceiving the first time? At what stage her miscarriage or abortion?
Let's say no problem to conceive the first time, and no symptoms. She just come back of the miscarriage and she wants to start again. Ultrasound done systematically, find an endometrioma of 4 centimeters.
I think asymptomatic small endometrioma should not be treated by surgery at the first time, especially when she did not have a problem to conceive. However, the miscarriage could have been with various reasons. Obviously, the poor quality of eggs because of endometriosis, but she could have ovulated from the other ovary, which did not have a problem. The toxic effect, but it's mostly applicable in case of IVF. So probably medically treat the endometrioma and then let her conceive, or try conceiving herself. Or she would have had a small endometrioma before, which would have flared up after the pregnancy happened. So, but definitely not surgery the first time.
Okay, no surgery. We have to answer to the question a little bit shorter because we have to go. I mean that now I have another case. I have a patient of 24, unmarried, with an endometrioma of 4, no symptom, discover like this. What do you do?
We give her a medical treatment with GnRH. Did you ask me or Hanan?
No, I ask you.
Go on. Go on. I would treat her medically and then let her conceive.
Okay, but if she don't want to conceive, she's not married. She don't want to conceive. So you say medical treatment. What medical treatment?
I would give her GnRH agonist. Either I go for Zoladex or for Vizan. Short-term treatment for 3 months. Definitely shrink the cyst. Obviously, and then we observe her symptoms.
Okay, Zoladex plus Vizan. Hanan?
No, Zoladex or Vizan. Give her both options.
Okay.
I will give her pill control after 3 months. I will give her oral contraceptive pill. But back to back. I mean, 3 months continuously and then withdrawal and then not cyclic pattern.
Well, what you will do, this young woman, 24, unmarried, no symptomatic, discover of a 4 centimeter endometrioma.
Short answer, contraceptive pills, cyclic or continuous, both are valid. No surgery.
Okay.
And also I put,
Now 3 of you, the same patient has pain.
For
patient with pain. What do you do?
Yeah, I would like to start to also symptomatic treatment with non-steroidal anti-inflammatory with contraception. I add non-steroidal, and if it is effective, that's it. If it increase, then I have to search for the reason of the endometriosis, which could be deep infiltrating endometriosis. And also I will continue with the medical treatment and further decision after, let us say, 3 months.
Okay, so you all agree medical treatment still to see if it works, and if it doesn't work, surgery.
You will definitely need a surgery, but an advanced stage. So now with the pill, we can stabilize the progression of her disease. And one day she will get married. Either she gets pregnancy, and this will stabilize more the endometriosis state, or she will have infertility. That time we intervene for the infertility and for this small pain.
Okay. Okay, 3 of you now. This young patient of 24 that has pain and you treat beautifully with different treatment, come back to you after a few months and she has now a 6 or 7 centimeter endometrioma. What do you do?
Surgery.
Okay, what kind of surgery, Anan?
Probably I would try sclerotherapy for her.
Sclerotherapy with alcohol?
Yes, with alcohol 90 degree. Avoid stripping her ovary and do the minimum. Do the minimum for her. Okay. But because...
I have to go fast. Rajesh?
Yeah, sure.
If she has identifiable cyst wall, I would still prefer to excise the cyst wall. And because she's young, to prevent recurrence, I have no experience with sclerotherapy. Or if the cyst wall is thin, I would go for a plasma ablation.
Okay.
Obviously, we have to do the ovarian function before that because she was with endometriosis for a long time and on medical management. So it is better to do the ovarian function, AMH or FSH, to assess her ovarian function levels, to know what effects it happens after the surgery.
Well,
really, after medical treatment and still the endometrioma is increasing in size, sure, we have to save the rest of the healthy ovarian tissue by surgery. And also, I do not have experience with the sclerosing therapy, so I go for careful, meticulous cystectomy.
Okay, so let's do thing because we have quite a good experience with sclerotherapy and amazingly it works. And so it would be very nice to make a larger study in the region and young patients because we have a lot of patients with ovary, and it would be nice to make a multi-center study to see if this sclerotherapy is effective or not.
My question, Professor, what is the rate of recurrence after sclerotherapy? Do you have any evidence, studies, or something like this?
But you have, it's good because this is a part of the question. I mean that you have a lot of study that shows that the recurrence rate is somewhere between the cystectomy and the simple drainage. It's higher than cystectomy, but lower than the simple drainage, and so it makes that. We have a series. We don't have 100 cases, but we have quite a number of cases. And amazingly, so far we do not have observed a recurrence. And so, and those were very big cysts in very young patients. And so we can observe, as you said in your presentation, Rajesh, and both of you, that the endometrioma is very rarely non-associated with more lesion, but just by draining the endometrioma and making this sclerotherapy, we thought that we saved the ovary without altering the ovarian reserve. And as the patient has no more sign, we just do that. And so it will be interesting. So this is not definitive, but it will be interesting in the long term to see if we serve if we serve the patient. I think it's interesting, very interesting study.
Yeah, of course. And there is also one interesting thing that, among colleagues that people think that when you find an endometrioma without deep infiltrating endometriosis, why do not you do the surgery? But what the matter of fact they do not think about is the deep endometriosis that is already there does not come to our vision enough to do the surgery sometimes. So this is why, like Hanan said, that we have to wait for some more time to get the deep endometriosis into vision to achieve complete excision.
There is a question, sir, and it will be the last question because we have to move with Dr. Saad.
Okay.
But last question: how long? Three of you, how long you can give Visan? How long?
Up to 4 years, 5 years, as long as the patient tolerates the treatment.
Rajesh?
I do not have a long-term experience with Visan. However, 1 year would be enough because most of the patients are looking at fertility and carrying on with the fertility treatments. In those cases, we do not prolong the treatment over many years. And if it is something long-term, probably Zoladex would be a severe disease. Zoladex.
And yeah, when we discussed this with the representative from the company, they said you can give it for long time, more than 4 years. But what is important, recently, it was found that if you give it continuously for more than 2 or 3 years, it will affect the bone mineral density. And this is very important. So now the new trend or the advice or recommendation by some authors to go for cyclic treatment first of all, and to be sure that it will not affect the bone density of your patient. So before I was giving it up to maybe 3-4 years, but nowadays I shift to cyclic, not continuous, for 21 days. And I take care of the bone mineral density of my patients. And then in this case, I have to shift for another drug.
Okay, so just to do a comment, probably because I'm French, I don't like too much lady without estrogen for a long time because of the mood, because of many things. So I would, you know, as you say, probably the bone density drop is associated with mood, depression, etc. So I mean, I think long-term Visan should be looked probably with caution. Thank you, three of you. It has been very interesting. So unfortunately, the time of the lecture should have been a little bit shorter to get more place for the discussion. We are going to forward to each of you the question that we did not answer, and they are dedicated for you, and you will be very welcome to answer as you can. It's time for me to move a little bit and to give the floor for the lecture, the sponsor lecture of Dr. Saad Aswad, that everyone knows in the region, about the role of the GnRH analogs in the management of endometriosis. And so Dr. Aswad is a consultant in gynecology, oncologist, and is very well known for being in Tawan Hospital in Al Ain. So Dr. Aswad, thank you to share with us your experience with this subject. And the floor is yours for the next, I don't know, 15 minutes, okay?
So you want me to speak for 15 minutes, Prof?
For how long you want? Tell me.
No, I'll cut it as much as you want. I'll try to cut it to 15, 20 minutes maximum.
No, yeah, do what you have to do. And everyone, we have still 534 people looking for you, so.
Right.
Please.
I think we'll start. I think I would like to thank really Prof. Arnold and my previous speaker, because definitely they make my life much easier. Again, really, I'd like to thank Rajesh. He spoke about surgery while about medical treatment. So this will make my presentation much shorter and I'll come quickly through it. So basically, really, we all know about what is endometriosis, where it is commonly placed, and it is becoming more and more, maybe not more prevalent, but it's more diagnosed. and it really increased in prevalence with low BMI. We know that there is genetic factor, and it is a major cause of morbidity and infertility across the board and in UAE. I just touch on that endometriosis is normally staged, and the older one was insane, and then the American Fertility Society had adopted the reverse or the revised staging process. So there are different stages, and this is just a summary of the stages of endometriosis. I'm going to touch mainly on severe endometriosis, which is the deep infiltrating endometriosis or rectovaginal endometriosis. And this is a common problem, undiagnosed mainly. And we need to admit that medical treatment is good in early stage endometriosis, but when it comes in severe endometriosis, surgery may be the first line of treatment plus minus medical treatment. I'd like to really remind you, I mean, if you're really good gynecologist, you'd like to see always the picture on the left, which is normal system. On the right, it is really very ugly and depressing. And these most of the cases of endometriosis. And what is really important, we need to appreciate that people are having endometriosis, they don't like sympathy. They need action where we can help them, number one, to reduce the pain and to have normal life and to have really children when they wanted. I'll just put some case for discussion, but I will not answer them now. I will answer them if there is some more time. And all these cases seen in our clinic, so nothing really unexpected. 18-year-old unmarried attended with her mother because she had pain, and ultrasound scan somewhere else reported 8 centimeters right side endometrioma. What would you do in these cases? So that's place for discussion, and put the answer on a side paper to see if this comes to the end to our suggestion. Now, what is really, I've been gynecologist. I established gynecology in UAE when I joined around the end of last century, but also I'm a strong advocate about establishment of endometriosis center. And Prof. Arnold really is one of the best example globally and in UAE where he established a endometriosis center of excellence. And this is really helpful in advanced cases, complicated cases, which we start to see more and more. It offers a wide spectrum of management, to have counseling with psychology support, nurse specialists, and they offer most of the time individualized care, and they provide the fertility need of the patient and high quality treatment. And I think really, we'd like to have Prof. Batiez in Dubai offering this in UAE level. Again, what is the aim of surgical treatment? The aim of surgical treatment, it should be mainly provided by laparoscope and should be by expert. I touch here on colorectal surgery, but if you have a good laparoscopic surgeon, then we don't need to have the colorectal surgeon or urologist. A well-trained laparoscopic endometriosis surgeon is enough to run the show, and it should have really aimed to maintain the pelvic anatomy and should have detailed surgical record. As I discussed, we have many cases come to us with question mark surgical management, but none of them have proper surgery. It was just open or laparoscopy and touch and close, and they tell the patient they have surgery. When you review the videos, they actually not done anything of value to help the patient. So you need to be sure about quality of life outcome, how the improvement of surgery on the outcome, and more importantly, about the pain improvement after treatment, especially if it was surgical. And if you have a good endometriosis center, then open surgery should be reduced to a minimum and should be done mainly laparoscopically. Now, this is my second case, a 32-year-old lady, unmarried, referred for a second opinion. She had 3 months, 1 episode of pelvic pain, and her surgery done by laparoscopy somewhere else reported stage 3 and 4 endometriosis with kissing ovary stuck to the back of the uterus with bilateral hydrosalpinx. The patient have no bowel and no bladder involvement, and she's asymptomatic. And she came and asked for a second opinion. What will you do in this case? Now, we'll go again. Surgical treatment facts. Surgical excision in general is recommended. I just heard about really the new treatment, which maybe remind me 20, 30 years ago, we used to have sclerotic treatment, the same what we used for really a coccus or hydatiform, where you inject something to kill the cell inside. So it's nice to have this study, Prof, to do some study on the AUA level to see the effect of sclerotic treatment in endometriosis, because I believe that if you go for surgery, you need to be excisional treatment with preservation of the ovarian function. You need to have a good surgical skill where you preserve the ovary and you aim to provide help, not harm the patient or long term. Incomplete excision will result in adequate treatment. Ultimately, women really, when they don't want to have any more children, you can be more radical and offer hysterectomy. Minor or moderate endometriosis can be managed by gynecology, but any advanced endometriosis should be referred to experts who provide the best treatment. This is a case which I saw myself again, 42-year-old patient, a teacher. She had endometriosis and she had CA125. She referred to me mainly because her CA125 is rising up markedly and moved from 200 within 2 or 3 months, moved to 450. She's 42, she completed her family. What would you do in this case? Now this quick diagram, which is the British Society of Gynecological Endoscopy Surgeons, but basically when the patient referred to you with endometriosis, and you need to be sure that you have specialized endometriosis center. You need to have full evaluation. And I always say in my really evaluation, a good ultrasound is adequate in a good hand. Sometimes MRI could help, but definitely the person who performed the imaging is the most important. So transvaginal ultrasound is important and MRI could be really helpful. And in deep endometriosis, rectal ultrasound could add a benefit, okay? Now, if the patient admitted, then really you need to do laparoscopy for advanced endometriosis, deep pelvic endometriosis. And normally a good laparoscopic surgeon should be involved, plus minus colorectal surgeon, urologist. This always comes to my mind because if you're a really well-trained gynecologist, I never call my urology part to help me with my surgery. I rarely call the surgeon. But if you're well-trained in your field, a good endoscopy surgeon should be able to deal with this. I rarely use the need of colorectal surgeon. And as I said, the two-stage surgery, you drain and treat and come back. But if you have a single stage, you need to give the GnRH, down-regulate, and then you do bowel prep and do the surgery. And if the patient completed her family, you might opt for hysterectomy and follow up really by special clinic, and you need to do further investigation to assess the response. And if there is any more symptoms, you might consider further treatment, or at the end when the patient complete family is really hysterectomy. I will skip this because I think our first speaker demonstrated well about the surgery, how it was in deep endometriosis, how it should be after treatment and opening the pouch of Douglas and really resecting endometriosis between the vagina and the rectum. And this is really an example of this. I think not many people really remember of the modem. Nowadays, patients come to us with really knowledge. So you need to be sure that you're at the top of the knowledge and you need to have faster access to knowledge. In the old days, we used to look at faster modem, but nowadays we don't use them, we use rotor. But you need to be on the top to answer all the questions. Most of my patients in cancer, especially with cervical cancer, come with a list of questions. So you need to be prepared to answer the question and show the confidence in your management. My first case is a 35-year-old lady referred for infertility, and she had really 5 centimeter endometrioma, and she had also endometrial polyp and AMH was a normal. What would you do in this case? Move on again to the pain management endometriosis. We really have the desire for conception and different pathway if you want fertility treatment directly or later on. I think most of the audience can really get in touch about this and review them later on. So I'll move on forward. I think I would like to thank Dr. Weil because he covered this extensively, and he spoke about non-steroid and anti-inflammatory combined pill, and he really covered this very well. Progesterone, and nowadays most of us use really the GnRH intrauterine system. Mirena have a place. Danazol, I'm not sure how many people, I would like to ask question, Prof, how many people use Danazol? Because Danazol, when I was in the UK more than 20 years ago, it was the golden standard. In my opinion, it is an awful drug. It is really good treatment, but awful side effect. So I think really Danazol have a place because it is cheap, but in the presence of very good treatment with minimal side effect, it's not on the front line anymore. We have gastrinone, and I'm supposed to touch mainly about GnRH analog with Zolidex. Definitely, it really using Zolidex in many different areas. It decreased dysmenorrhea, dyspareunia, and it reduced pain related to endometriosis by some study by 93%. It caused amenorrhea, but if you give Zolidex with iron, the return of HP to normal is much quicker, and it is definitely better than placebo. It's as effective as Danazol, but much better accepted, and the side effect acceptable, especially with add-back studies or treatment. The only problem that if they approve it for 6 months, you need to be sure that you use it only for 6 months. And as I said, add-back HRT or hormone treatment, as Dr. Weil mentioned, is quite good. Now, the medical treatment, as I said, the Zolidex and add-back therapy, possible aromatase inhibitors with oral contraceptive, whatever, should be used not as first line, but as second line. As Dr. Hanan and different speaker mentioned, maybe the first line in early medical treatment, you might consider the combined pill, back-to-back, continuous treatment, progesterone, but use GnRH analog only in second stage treatment and in combination with surgery with advanced stage endometriosis. There is some really empirical treatment. People use Zolidex without reason, but definitely you need to think about the cost and the side effect. And recently I have a patient who, as I told professor, tried everything possible. And at the end, really, she had severe symptom related to everything possible. And I tried to use Zolidex, and she came really with throbbing headache, severe headache. I need to send her to neurologist to exclude brain problem. But Zolidex have a cost, so you need to be sure that you only prescribe it as good indication with good support and well-defined links and after full consultation with the patient. Now, as I said, the best time for me for using Zolidex, it was mainly as pre-operative in fibroids sometimes and post-operative in endometriosis. And I find it's really improved our result and improvement in pain control and relief of symptoms for a longer period. And there are many studies, especially Cochrane really 2004 published, that inefficient evidence to show benefit of hormone replacement either before or after. But nowadays there is enough evidence to suggest add-back treatment is helpful. Hormone treatment, both operatively, definitely it improves the outcome. If you add hormone treatment like Zolidex to the surgery, it reduces recurrence of endometrioma to 10%, but without hormone treatment, it is 40% recurrence. Sometimes using IUS system, it could be helpful. So really, hormone treatment, the way of GnRH or Mirena, will definitely improve the outcome of surgical treatment in preventing the symptoms and the disease recurrence. I'll touch just more quickly on Zolidex. We know that GnRH have many forms. In the old days, you have the spray, we have different names, but I'm touching mainly on Zolidex, which have 2 doses, the monthly dose and the 3 monthly dose. And it mainly works on suppressing the hypothalamic pituitary axis, reduces the FSH, LH, reduces estrogen, And by the end of 1 or 2 cycles, you have no estrogen and no menstruation. As I said, it have effect on breast and it have systemic effect and bone density effect. So I think I wouldn't give myself Zolidex more than 6 months. All my colleagues in oncology, especially breast cancer, use it for longer term. So I think, yes, an FDA approved for 6 months and medical treatment. When it comes to cancer, it's used for a longer period, and they use a 3-monthly cycle, subcutaneous injection every 3 months. Now, just touch on the main use. We all know that it uses endometriosis, adenomyosis. I'd like to really thank Dr. Hanan. He spoke about the adenomyosis and adenomyectomy, and I am pleased to say that it have high chance of uterine rupture. We used really Zolidex with fibroid. It helped in male and female infertility management, but in cancer also it really cover, definitely used in prostatic cancer and it cover in breast cancer. We use it rarely in precocious puberty and delay puberty for young patients who really come to us with puberty at 9, 10-year-old. The mentioned side effect is hot flashes, insomnia, loss of libido, dryness, and emotional instability, and loss of bone mineral density. So all this could be reduced by giving add-back treatment. As I mentioned earlier, adding Zolidex in treatment of fibroid, it improves the HB of the patient in a shorter period with adding Zolidex to iron. Now, this real overview by Cochrane Brown, he mentioned that for women with pain, endometriosis, suppression of menstrual cycle with GnRH analog, an IUS and danazol were beneficial intervention. So definitely with Cochrane review, treatment with GnRH have benefit in endometriosis. And if we add it to laparoscopic treatment, is definitely beneficial. As Dr. Weil mentioned, that non-steroid is questionable and not conclusive. You might use it with the combined pill, but there is no evidence yet that it have any help alone. And as I said, with women going with assisted reproductive, 3 months of treatment with GnRH agonist improve pregnancy rate. So adding GnRH to the treatment of endometriosis in many studies improved the pregnancy rate and outcome of treatment of IVF. Another study by Song et al., it really compared laparoscopy alone and laparoscopy combined with GnRH, and it found that this is definitely more effective treatment in lower recurrence rate, higher pregnancy rate, and fewer adverse reaction. So in this review by Song, adding GnRH to laparoscopy treatment in advanced endometriosis will definitely have significant benefit in the outcome of long-term treatment. Another study by G, and this study again looking at 206 patients with severe ovarian endometriosis under surgery, and it was the result of this review, conservative laparoscopy surgery combined with goserelin, which is type of GnRH analyte, could reduce the recurrence risk of severe ovarian endometriosis, improve pregnancy rate, and fertility. So again, in many studies now available, that combining surgery in a good hand, and I stress the importance of a good hand, not just open, touch, and close. With adding GnRH analog, it have definitely improved outcome on the recurrence, the symptoms, and fertility outcome in patients who seek fertility treatment. I'll really skip this because again, this confirmed that Zolidex for 6 months after surgery will improve the outcome of treatment. And you can see again that adding Zolidex post-operatively will improve the outcome of treatment and improve the symptom, especially pain related to endometriosis. Now, what is really important that if you look at endometriosis and Zolidex, using treatment to improve symptoms in 93% of the cases by the end of treatment. This meant to be 6 months of treatment, there is improvement in symptoms. And at least by, I think, the end of 2nd and 3rd months, 89% of the patient will become amenorrheic. And this is the purpose of treatment, to reduce the estrogen factor and reduce the endometriosis. So we'll go back to my cases, and I'm coming to the end of my presentation soon, Prof. So in the 18-year-old patient, unmarried, lady attended, and she had really ultrasound, suggest 8 centimeter. I think the only person who can contribute is Prof. Arnold. Do you have any suggestion, Prof, on this case?
Not yet. I wait the end.
Fine. So I think what I did in this case, the patient is very young, but she have a large endometrioma. And as Dr. Wael mentioned, what does it mean large? We don't know. In the past, it would be 3, 4, 5. Dr. Wael mentioned 5. I think in this case, I might consider medical treatment, but I might consider limited surgery, and I might consider in the future using sclerotic surgery when I know about it a bit more. And I'll listen to your comment about this. Now, in the second case, which is a 32-year-old unmarried referred for second opinion, she have 3 months episode of pain. Her surgery reported documented stage 3 and 4 endometriosis, kissing ovaries, and back to the uterus and hydrosalpinx. But the most important part, there is no bowel and no bladder involvement. Patient is asymptomatic, and she came 3 months after surgery to ask for opinion. And I think I will maybe leave it for both, but if it's up to me, as the patient have no symptoms, no bowel and no symptom, I might consider observation or only adding some progestogen treatment, but definitely I wouldn't go for something major. Now, this is really interesting because over the years, I have to admit that I have many cases referred to me as ovarian cancer, and after full investigation and assessment, they came as endometriosis. But to a lesser extent, I have patients sent to me as endometriosis, and a smaller number came as endometrial cancer. So this 42-year-old patient who is a teacher, she completed her family. My concern about CA125 going up quickly, and I think she had no previous surgery, but she completed her family. I think with the rise of CA125 quickly, I consider surgery, and in this case, the patient have early stage endometrioid endocarcinoma of the ovary. So please, when you deal with endometriosis, you need to be sure that you have good imaging and be sure it is endometriosis, not early stage endometrioid ovarian cancer. And if the patient completed her family and she already have some warning sign, which is the raising CA125 quickly, you need to act. Case number 4, I think this patient definitely is 35 and she's seeking infertility treatment. So I wouldn't delay the treatment. I'll go for conservative surgery. And as she had endometrial polyp, I will definitely remove the polyp at the same time. So I'll go for infertility treatment with surgery and add some GnRH analog, maybe up to 3 months after the surgery, and this hopefully will improve her outcome. My last case, which is just really a case, not endometriosis, but fibroid. And this is a 42-year-old patient who is married, but she tried for 15 years to get pregnant, never got pregnant. She came with large growing fibroid filling up to the umbilicus. And this is really suspicious. When she sent by MRI, it was suspicious of sarcoma. In the past, she had a mammectomy 9 years ago before her presentation. And after a mammectomy, she had deep vein thrombosis, resulting in putting a filter in the inferior vena cava. And due to insurance problem, didn't remove, but 9 years ago, she had IVC filter to stop any more emboli going to the lung. And she came to us with highly suspected sarcoma of the uterus. Now, the patient went through full assessment as sarcoma, and she went THPSO, but when we did CAT scan, there was multiple lung nodule. And as you can see, they are really clear lung nodule. We thought we were dealing with sarcoma. When the histology came, this came as histology of fibroid or leiomyomata of the uterus, no evidence of sarcoma. what is next? I think with this big lesion, we needed to do lung biopsy, and we did CAT scan guided biopsy, and this came as benign metastasizing leiomyomatosis, which is a benign fibroid, but has the tendency to spread. By the way, I have many cases of metastasizing fibroid into the intestine and omentum, but this was one of cases where the fibroid, although it's benign, but spread to the lung. Now the patient already have hysterectomy, salpingo-ovariectomy. We observe her and we find that the masses are not reduced in size. We started on GnRH analog, Solidex, and after 9 months, there was reduction in the size of the secondaries. This confirms at least this is number one, it is fibroid. Number two, although the patient have no ovary, but still with Solidex, there was reduction in the size of the lung nodule. And we stopped and observed to see if this re-increase in size or stop. So if I want to conclude, Prof, advanced stage endometriosis should be treated in specialized endometriosis center. And I could stop here because this is really crucial. Nobody should be allowed to touch endometriosis, especially deep endometriosis, infiltrating endometriosis, only unless they are trained and certified to this. And the endometriosis center should be providing multidisciplinary team who can provide the best care emotionally, psychologically, and medically to support the patient. Conservative laparoscopic surgery combined with Solidex and treatment of stage 3 and 4 definitely reduce the chance of recurrence of the endometriosis, improve pregnancy rate, and endometriosis associated infertility. And again, going with endometriosis and Solidex or GnRH analog, there is improvement in many studies that the assisted reproduction outcome is better and improved pregnancy rate. Last sentence, as Dr. Weil said, laparoscopy combined with GnRH analog is more effective in treatment of ovarian endometriosis and exhibit lower recurrence, higher pregnancy, and fewer adverse effects. Just acknowledge that many of these slides taken from my colleague because I was asked to do this presentation only 2 days ago. Thank you.
Thank you, Dr. Saad. For 2 days is very good.
I'm not the expert on endometriosis, but I dealt with many cases as second hand.
Yeah. So thank you for this very nice presentation covering excellently the subject. Alors, we had few questions. In fact, we have 3 questions, which is a little bit on the side of your talk, but there is a question for you. What is your position for the Mirena in endometriosis and fibroid?
Me, asking the question. Yes, I never used Mirena in fibroid. I may consider using it in limited space and adenomyosis. I will go for more aggressive hormone treatment, medical like progestogen or GnRH analog for endometriosis. Although the people added as add-back treatment with Solidex, but I never used Mirena alone in advanced endometriosis or fibroid.
Yeah, I agree. I agree with this. You have a case, now this is about the same case about the Mirena. So case with adenomyosis and myoma, 50 years, endometrium is clean, Mirena reduce her menstrual flow. Can we continue or shift to hysterectomy?
I think you touched on the question. I was going to cover this, but Dr. Hanan covered more extensively. But I could tell you, I deal with many VIB UA national here, and I have many cases of very severe adenomyosis, and they will not accept the idea of hysterectomy. Mm-hmm. And I will tell you my experience here. We have 3 methods, and I would like to hear you comment on them. We have uterine artery embolization in advanced cases, like uterine fibroid embolization, and it shows some promising effect because we embolize the uterine artery, And in many review of our cases, there is up to 50% improvement in symptoms. I have many cases who opted for Zolidex treatment, and after 6 months treatment, they improved symptoms and they did not need to have hysterectomy. May we need to repeat the cycle after 2 or 3 years, but they did not agree for hysterectomy. Again, so if you combine Zolidex, cyclical for 6 months, a stop for a year or 2, and check bone mineral density, and uterine artery embolization. I yet didn't use Mirena, but I use endometrial ablation. When you use Zolidex, after 6 months, the uterus will shrink. So you might combine it with thermal ablation of endometrium, and 2 cases I put Mirena, and it worked. Because you need to shrink the size of the uterus to 10 centimeter, and combination of Zolidex, embolization, and Mirena helped. And yet I did not remove any uterus in patients who insist to keep the uterus irrespective of her age. And by the way, Prof, I have a patient came to me 2 days ago. I think you, Muna, and different people saw her. She is 47. She had multiple fibroid. Logically, she is for hysterectomy. But I have many patients who are above 50 and doesn't want hysterectomy, want myomectomy. I don't know what you think about this patient condition management. What is your view about what I said, Prof?
I think that you are perfectly right. So, I mean, first of all, we probably should not remove a uterus to a patient that do not want. I think this is very important because we are going eventually to replace a pathology by another one, which is probably more problematic, which is depression, etc., etc. So I think that the first person we should accept the indication of hysterectomy is the patient. I think it's very clear. Now, the problem we have is that now if you do a myomectomy or multi-myomectomy in a patient of 50 plus, and you have a complication, you will be very, it will be very difficult to defend you if you have an investigation. Because after 50 or, you know, when a certain age, the treatment of trauma are recognized to be hysterectomy. So that, but here, as you say, the culture is a bit different and patients are more keen to keep their uterus. So I think we should push a little bit the indication. And we have, as you said, we have to use different protocol to try to maintain the uterus. In an other hand, and this is what I have observed since I'm here, with good consolation, with discussion, at the end of the day, we succeed. At the end of the day, the people accept the hysterectomy when it's needed. And with this result, basically, they are quite happy with the result of the surgery. And so, because I think at the end of the day, for many cases, as you described, if you have a 55 patient with adenomyosis, fibrosis, etc., and symptoms, the best operation for her would be hysterectomy. We all agree on that.
I agree 100%.
And so it means that our duty as a doctor is to try to convince them. But this is a vast discussion, and I think we have to do the best for the patient. And the patient is really at the center of the diagnostic. So we have to cope with the culture, with the desire, and try to do our best.
Thank you,
I
Prof.
have a question, and again, that means that we still have 500 people looking. So it means that all of you have been perfect. And I think we already answered to the duration of the GnRH medication. Question, is there any role of GnRH in the treatment of adolescent endometriosis? I don't know.
I think Wael mentioned about it, but I think I'll be more conservative for middle age and older women. I will try to do more benign hormonal treatment like combined oral contraceptive back to back, or I might go to GnRH. but yet I wouldn't prescribe Zolidix for endometriosis in teenager group. I might consider, I have 1 or 2 cases with a pediatric developmental doctor neurologist where we give Zolidix for delaying puberty, but I wouldn't consider Zolidix in teenager group yet.
Okay. Question and last question, I think. GnRH analogs produces hypoestrogenism. How progesterone acts as add-back therapy?
I think, as Dr. Wael mentioned, fortunately in Tawam, we have Levial, we have Brigiliton, and we have Primarin, and all of them at small doses. So in the past, I used to wait for a month or 2. If the patient have symptoms related to the Zolidix, I start add-on treatment. But nowadays, especially in young patient, I might add the treatment early on with Zolidix in the first month of treatment. And it have definitely improved markedly in the acceptance and tolerance, reducing the side effect of GnRH analogs side effect.
Yeah, you agree. I have actually a young patient, which is 27, that I follow since 5 years with medication, and she has a huge endometriosis with a big bowel nodule, non-obstructive, but quasi. She has no symptom, and I keep it under medication since 5 years now. And she is with agonist and add-back therapy. So I mean that we can play a little bit, and I think that you and all the speakers have mentioned that endometriosis is a very very difficult disease.
Can I say something, Prof? Can I say something?
Yeah.
I think as a gynecologist, when you deal with cancer, either you cure them or kill them. Mm-hmm. But with endometriosis, they have a long-term and long treatment, which is more taxing for the doctor, because as you mentioned, the patient will come to you for 5-10 years. In cancer cases, after 5 years, they are cured or dead. So I think you are really managing endometriosis is more difficult to handle cancer, in my opinion. I don't know what you feel.
I fully agree. I used to say that the surgery is a drop in the ocean of the treatment of those patients. And so I mean that you have to see those patients many long time before and really long time after. That is a big lesson in your life about to be humble as a surgeon, because on some patients you have great success, in some patients you have great failure. And so that brings to the field what you said, at least what we can offer to this patient, like for cancer, that to be treated by people who knows. And so I think I fully agree with you when patients should be seen in centers, and even for beginning case or early case, because they have to be taken in an agenda of treatment that, as you say, will last for long. So I think that to conclude this seminar, because we are late, and I don't know what time it was planned to finish, but it means I always say that a course of a webinar which is late is a good one. It means that we had something to say, and looking at the people that still are there with us, almost 500, I think that we have done the job beautifully. So as you see in your screen, the CME will be available in 10 days. You have to fill the evaluation form if you want to get your CME credit. And I think it's a good process, because there is no education without feedback. We need your feedback to find if we are on the right way, what we have to change. And this is very important to fill the evaluation form. The webinar will be available on the YouTube channel, and you have the address right on your screen. So I let you take a picture. And last but not least, I want to thank all the 4 speakers, Dr. Wael Samour, Dr. Rachid Devassi, Dr. Hanan Garbi and Dr. Saad Aswad. You have been fantastic. I have learned a lot of things thanks to you. I want to give you an appointment for the next EOGC webinar, which will be in the iron deficiency and immune system in March 2021. And thank you for all the speakers. Thank you for AstraZeneca to give us the opportunity. Thank you also to MCI to have secured the organization. And I give you the appointment. I don't have the day, but March 21. And from my side, I cannot leave without inviting you. Now in 2 weeks, we have Endo Dubai. So Endo Dubai will be online this year, unfortunately, but we have concocted a good program. So look at endodubai.com and you will see everything that we have prepared for you. I give you appointment for that also. Bye-bye, everybody. Have a good night. Be safe and see you soon. Bye-bye.
Bye-bye.
Bye-bye, Arno.